Welcome to the recorded version of Improving Healthcare for Persons Living with Dementia from September 12, 2018, part of the National Alzheimer's and Dementia Resource Center webinar series sponsored by the Administration for Community Living.
Thanks, Steve. Welcome to the webinar today on improving healthcare for people living with dementia. In this webinar series, the Administration for Community Living National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're pleased to have all of you in attendance today. For today's webinar, we'll hear from three speakers, Debra Cherry, Laura Connolly, and Katie Scott. Debra Cherry is the Executive Vice President of Alzheimer's Greater Los Angeles. She has served as co-director of the Dementia Cal MediConnect project and has over 2 decades of experience leading healthcare quality improvement projects focused on dementia care. Laura Connolly is director of the California Department of Aging, which administers the Older Americans Act services through the state's 33 area agencies on aging, as well as the Medicaid HCBS waiver, which annually serves approximately 11,000 older adults, and certifies more than 240 adult day health care centers for Medicaid participation. For the past 16 years, Laura has also co-managed a series of Federal Administration on Aging dementia grants in partnership with the state's regional Alzheimer's organizations. Katie Scott is Senior Director of Dementia and Caregiver Support Services at Baker Ripley, managing a dementia-specific adult day center, caregiver support services, dementia-specific case management, and regional and state initiatives to improve dementia care in Texas. Katie Scott also serves as the Project Director for Texas Takes on Dementia, a statewide initiative to improve care systems for people with dementia and their families who are enrolled in the Texas Dual Eligibles Integrated Care Demonstration Project. And I will turn it over to our presenters at this time to begin. Debra, I'll start with you.
Thank you. Thank you, and it's good to be here with everyone. You know, we wonder why it is when we look at many health plans and healthcare systems that they have disease management programs for diabetes, for congestive heart failure, for many other conditions, but not for dementia. Why should healthcare providers focus on dementia? And I think if you are someone who is interested in having them do so, either from within a healthcare organization or the Aging Services Network, you need to know what the business case is for working on dementia. And it starts with the prevalence of the disease. And as you can see on the slide, risk is increasing in our society over the years, and the risk is particularly increasing in not the risk, but the prevalence of dementia is particularly increasing as the population ages. So prevalence is greatest in the old. Here they're categorized as those 85 plus. And this is a population that is growing faster than all other populations of older adults. So dementia is reaching an epidemic proportion, and healthcare organizations need to know that. This population is an expensive group. Dementia does not happen in a vacuum. People who have dementia often have other comorbid conditions, and often these conditions are poorly managed. And if you look at the slide, you'll note data suggesting that these patients cost Medicare 3 times more than other beneficiaries of the same age group, and that's driven primarily by hospitalizations. They cost Medicaid 23 times more than other Medicare age beneficiaries, primarily because of nursing home placement. So it's an expensive population, and it nevertheless does not often receive the best quality of care. And some of the problems we see with quality in people with dementia is that the disease is poorly detected. We know that most data suggests that only 50% of people with Alzheimer's or related dementia get a diagnosis. About half of them get it documented in their charts. So when we ask a healthcare organization to run their ICD-10 numbers or their other numbers, we often tell them, now multiply it by 4 and you'll probably have the number of people enrolled in your system who have Alzheimer's disease or related disorder. Furthermore, there's limited recognition of the informal family, often caregiver's role, And yet these caregivers are responsible for disease management as well as for all home and community-based supports that their relative needs. So they are natural partners to the healthcare organizations, and they are not recognized. And then finally, healthcare organizations have only recently started to pay attention to social determinants of health and the use of home and community-based services, long-term services and supports are not seamlessly connected to healthcare, and that would really benefit quality if they were. So looking at these challenges and at current best practices, our project generated 3 indicators of dementia capacity for the health plans with whom we worked. 1, better detection of patients with dementia, and that includes having the health risk assessments that they use, do a cognitive screen, having all of our health plans that we worked with adopt a validated screening tool for cognition when the health risk assessment suggested that it was necessary or when there were patient or family complaints. We wanted the health plans to document that assessment in the e-medical record and establish a follow-up protocol if the screen is positive. That's indicator 1, better detection. Indicator 2, better caregiver identification and support. We wanted caregivers identified and documented in the medical record. We wanted a validated tool to be used to assess the caregiver's needs, and then once those needs were assessed, we wanted the caregivers to be provided with education and supports. We also wanted both the person with the disease as appropriate and the caregiver to be engaged in the care planning process. So this didn't just happen by professionals without input from those impacted. And finally, a care plan would be developed that's based on both the person and family-centered needs. Finally, indicator 3 was we wanted to see better connection to home and community-based services. And those services are many. We knew that people needed dementia education, but they might need things like meals or a support group. They might be connected to housing organizations. There is a full range of home and community-based services that families needed and that needed to be more accessible to them. And I think at this point, let me turn the presentation over to Laura Connolly, Director of the California Department of Aging. Laura?
Thank you, Deborah. Deborah just shared with you the 3 key indicators of a dementia-capable care system, kind of in our conceptualization. Here in California is one of the states that's been participating in the Centers for Medicare and Medicaid's Fiscal Alignment Initiative, which we generally refer to as our duals demonstration or Cal MediConnect, so you'll hear me use those terms interchangeably. We've had a unique opportunity since 2012 to help build components of a dementia-capable system into our initiative. This effort was funded in large part through the Administration for Community Living's ADSSP grants, with the generous support of a number of other foundations and funders that are listed here on this slide. And I'm just going to briefly touch on the organizations that have been involved because it has been a large effort. Oops, and let me just put my cell phone on mute. Sorry about that. Clearly, as I referenced, a key impetus and opportunity for us was the funding from the Administration for Community Living in terms of undertaking this project. The Department of Aging is the grantee through this project, and Alzheimer's Greater Los Angeles has been our subcontractor. Key in our effectiveness and just even undertaking this project has been our relationship with the California Department of Healthcare Services, which is our Medicaid agency here in California. And then Department of Public Health also has Alzheimer's related programs housed there. So they've been part of our steering committee effort. I already mentioned this Alzheimer's Greater LA as one of our key partners in implementing this project, as well as the Alzheimer's Association of California and Alzheimer's San Diego. Our evaluator for the project is the Institute for Health and Aging at the University of oops, I was going to say Southern California. That was an oops. The University of San Francisco. University of California at San Francisco. I'm showing my alma mater colors there as a Freudian slip. And then listed below that are the health plans that have been participating in this project, which is all of the health plans involved in CalMediConnect. Under the CalMediConnect program, the health plans must include all Medicare and Medi-Cal services, primary and acute, prescription drugs, most behavioral health, and long-term services and supports. The one caveat to that in terms of the long-term services and supports is that our very large in-home supportive services program, which is a self-directed personal care benefit, continues to be operated by the county social services agencies. The plans also include supplemental benefits and those that previously had not been available and are listed here. Care management is a key component to what was envisioned in developing the duals demonstration, and I think is essential in achieving its success. By integrating the continuum of health and long-term services and supports, the goal is that health plans can achieve savings on the acute care side by providing additional supports through care management, preventive care and disease management, and home and community-based services. The plans also have the flexibility to apply savings achieved toward other types of community supports that they previously would not have been able to provide. Each health plan is required to use risk stratification mechanisms or algorithms as individuals enroll in a plan, and higher risk individuals must be assessed within 45 days of that enrollment using a health risk assessment, and then others who do not meet that high acuity level must go through an assessment within 90 days. And that will come into play as we talk further. Policy levers. This slide really, the prior slides noted the goal of overcoming the funding silos inherent in these major health and long-term care delivery systems, and embedded in CalMediConnect, the CalMediConnect plans contracts are quality improvement targets and a focus on promoting partnerships with community-based organizations. This work also seeks to acknowledge and engage caregivers, whether they be blood relatives or families of choice, to assist them in their key role and to support the support that they provide on an ongoing basis. I should note that the California Duals demonstration contract with CMS and health plans required the plans to have a dementia care specialist. And this was a new requirement for the health plans, even if they had been involved in similar type of activities with CMS in other states. So this was new. And one of the key things that Department of Healthcare Services did as the project was getting underway was to issue an informational bulletin to the plans to reinforce the importance of addressing the needs of plan members who were diagnosed or who had diagnosed or undiagnosed dementia, both in terms of the care need and also as a cost driver, and reminding them about this dementia care specialist requirement. A couple of the plans who had been working on these issues in other states just really didn't believe that this was a requirement, and so this bulletin helped to drive it home that yes, in California it was a requirement. And after the initial rollout of CalMediConnect, DHCS also convened a work group to provide input into developing a core set of questions that all of the health plans would be required to use in their health risk assessments moving forward. And based on that process, questions were added that could flag cognitive impairment issues, and all of the plans must now include that item in their health risk assessment. I know in some of the other states, they began the effort with a standardized health risk assessment that evolved to become core items that were included here in California. Most of the major components of this work have been done by the Alzheimer's organizations, and that has included a significant level of advocacy at all levels focused on the opportunity and the need for better dementia care. Debra spoke to that just a few minutes ago in terms of her presentation. Focus on adapting an evidence-based dementia care management curriculum for use with the health plan care managers, and then scheduling and conducting all of this training. And that was no small feat, given the number of health plans and the geographic differences here in California. Third, providing technical assistance to the health plans on an ongoing basis. And this was a role that hadn't originally, I think, been identified, but evolved. The health plans really wanted the organizations to be participating in their internal as well as external advisory groups, which was a good thing, but time-consuming, certainly, in terms of that participation. And then providing information, assistance, and supports to health plan members and their caregivers, and helping in the planning for the road ahead. Key steps in the partnership, clearly I think we've narrowed them down here to 4, but there are probably even additional ones. First, in undertaking this project, identifying key champions and leaders within the health plans. It's very important. It yet sometimes can be challenging, a challenging step, especially when health plans are going through mergers, and that has been the case kind of over the entire time frame that we've been implementing this project. In terms of making the case, much of what Debra just presented are the key messages that were made to the health plans in terms of the prevalence and the cost, and presenting the plans with strategies on how they could make a difference. And that the health plans can rely on these organizations to provide them with clinically sound and realistic technical assistance to make changes that really will improve dementia care. And then, equally as important, coming through and actually doing what you promised you would do. And at this point, I'm going to switch it back over to Debra. Thank you.
Thank you, Laura. So let me mention that our business case materials are available on our website. At this point, we have done basic training for 500 care managers that include what are the fundamentals of the disease, and taught them how to use the ADA, a screening tool that is validated and can be delivered by phone and in a variety of languages. We also taught the care managers practical behavioral symptom management. You'll hear more about IDEA and the caregiver tip sheets in a moment. We taught them about the importance of identifying, assessing, and caring for that caregiver. And we taught them about how to access home and community-based services. Now, we believe that training is important, but it's a basic for change, but it is not going to create change unless you give people tools that make it easy for them to make the change happen. So here are some of the tools that are available to all of you, again, through our website, which appears on the slide. One of them is plain language caregiver tip sheets on 15 different topics. You see the topics listed here. And these tip sheets are now available in English, Spanish, Chinese, and Japanese. And we even will work with you to have you be able to co-brand the tip sheets with us in your local community. So we taught them about how to manage challenging behaviors. We gave them materials on managing challenging behaviors like bathing, refusal to bathe, getting lost, etc. We asked them to make referrals to community-based organizations, and our project used a form that is not unique to us, but was helpful, called ALS Direct Connect. Most of the time, healthcare providers make a referral when to a community-based organization when a family is in crisis. That family might be at the point where they're ready to use a nursing home. Or they give the family a phone number and say, call this number and the organization will help you. Well, families don't call until they are in crisis. And therefore, we asked the partnering healthcare organizations to ask the family if the local Alzheimer's organization could call the family member directly. And that's what ALS Direct Connect does. It gets permission from the family to have a local community-based Alzheimer's knowledgeable organization contact the family directly to provide supports, and it allows that organization to provide the clinician or the care manager with feedback on what kind of services were provided to that family. That tool and all other tools are available on our website in a Dementia Care Management Toolkit. And amongst the tools that you can get from our website are sample health risk assessment questions. We found that some of our health plans originally were using health risk assessment questions for psychosis and mental health issues and calling them their cognitive screens. So we have some sample health risk assessment questions, some sample curricula for the care managers that you can download, ALS Direct Connect, our care management toolkit, some screening tools, some caregiver assessment tools, not just the one we used, which was the Benjamin Rose Caregiver Stress and Strain Scale, some care needs assessment tools derived from a program called Access, an evidence-based care management program for dementia, IDEA, a 3-step strategy for managing challenging behaviors of dementia, some best practice care plans that care managers can use that sort of correspond to those lower literacy caregiver tip sheets and the needs that families commonly express. Now, again, all of these are available for you to download. To date, we have trained caregivers at 10 health plans. Nearly 500 care managers, I'm sorry, I said caregivers, but I mean care managers, have gone through an 8-hour training. In addition, at 9 of these health plans, 109 care managers have gone through what we call dementia care specialist training. It's an additional 12 hours of training. This training was developed by Alzheimer's LA, and it was delivered by our organization, the Alzheimer's Association in Northern California, and Alzheimer's San Diego. An evaluation to assess the impact of our project was done and is still being analyzed and completed by the Institute for Health and Aging at UC San Francisco. And we wanted to see whether there was actual system change and behavior change in the care managers that we trained through our project. For the care managers, we wanted to know, had we improved their knowledge of Alzheimer's disease and related dementias? Did they report better practice change or outcomes for their patients? Did they report that their systems were changing? And we administered pre-post training and then 6-month post surveys. The system change tracking we did slightly differently. In addition to what the care managers said in their post and in their rather 6-month post surveys, we had project staff speak with key informants at the health plan and observe what was happening at the respective health plans assigned to each of the organizations. And we tracked changes that we observed happening that we thought showed that they were being embedded or baked into the system. We are currently with UCSF going back and confirming the findings that I'm going to report here today on system change. So what did we learn? And this is a real shortened synopsis of what we learned. Yes, there was, not shown here, is there was great improvement in knowledge about Alzheimer's disease, the role of the caregiver, the importance of home and community-based services. It was sustained for 6 months, even 6 months post the training. However, we also found that the care managers reported that they had changed their practice. There was a trend to their encouraging the families and the individuals with dementia, and I have to say most of our individuals with dementia were were in the moderate to severe stages. Again, we're talking about a dually eligible population, and that's why so much of the work is done with the caregivers. So there was a trend toward encouraging caregivers to get their relative a formal diagnosis. It did not reach significance, but it went from 68% before training to 81% 6 months after the training. There was a significant increase in determining whether a person identified as having dementia had a caregiver. 68 pre, 82% 6 months after the training. And these caregivers were more likely to be involved in, say these care managers, that these caregivers were more likely to be involved in the care planning process. Both the caregiver and the member was more likely to be referred to home and community-based services after the training. And these are all highly significant results. You can see the numbers there at the bottom of the slide. And a great increase was made in making referrals of these caregivers to local Alzheimer's organizations, with the pre-training number being about 49% of the care managers saying they made referrals, to 95% of them saying this at 6 months after the training. So there was a significant self-reported change in practice behaviors. And then we took a look at, do the health plans, have they been making changes in how they, in the 3 areas that we were concerned about: better screening, better caregiver identification, assessment, engagement, and more referrals to home and community-based services. And what we found was that there were 10 health plans altogether. 2 of these were added in only the last 18 months, and so you wouldn't expect them to have the same impact, have had the same impact upon their systems as the 8 that had been involved in the project for 4.5 years. All of the health plans, and this is largely because of advocacy and the engagement of our state Medicaid agency, all of the health plans now have at least one question in the health risk assessment regarding cognitive issues. 6 of the health plans have incorporated, adopted a validated screening tool, usually the AD8, and integrated it into their e-health records. And these are mostly medical management records used by the care managers. 5 of the health plans have protocols to refer members for a diagnostic evaluation if that screen is positive. Under caregiver identification, assessment, and involvement, 9 of the plans report documentation of a caregiver. And I would note that they should all be doing this because it is a requirement of the state, but only 9 do it, and that's still great. 4 of the health plans report that they were engaging caregivers in care planning and in interdisciplinary care teams, which is seen as a best practice within MediConnect. And 2 of the health plans adopted a validated measure of caregiver stress and strain and integrated it to their electronic health record. A third health plan is in the process of doing this now. 6 offer respite as a care plan option, and 1 offered other non-covered long-term services and supports to families. We think that respite is offered, but not often is not often given. So we would certainly love to see more uptake, but at least they are offering it as an option. And then 6 plans offer a range for caregiver education for the families and informal caregivers of people with dementia. 4 of the plans have formally adopted ALS Direct Connect. A 5th is on their way to putting it into their e-medical records, so we are continuing to move in that direction. And we know that all of the health plans, I should say 9 of the health plans, are making referrals to Alzheimer's organizations. The one health plan that is not was one that joined very late, the one Laura mentioned, that didn't know that they needed a dementia care specialist in their system of care. So an example of what we've done is Molina Healthcare. Molina Healthcare is not only local but a national healthcare. They have changed their health risk assessment to better identify members with memory concerns and to track recent changes in cognition. They added a validated tool to their clinical software to screen members for dementia with the AD8. And they've created a tool to inform primary care providers about the AD8 score. They also use their health risk assessment to identify caregivers of those with dementia and assess them using the American Medical Association's caregiver self-assessment tool, which was added to their clinical system. And their care managers do assist to link caregivers to appropriate resources based on needs identified through that measure. Now, I will say that most health plans when they incorporate change in one line of business, they generally adopt it across all lines of business and nationally as well. But in other locations, the health plan may need a nudge to, health plan staff may need a nudge to be educated about their own systems and new procedures. So I want to end by saying thank you to the fabulous Dementia Cal MediConnect project team. Everyone is listed on this list, and to encourage you to go to our website at alzgla.org/professionals and download the materials to use in your area. And now I would like to hand the presentation over to Katie Scott of Baker Ripley in Texas.
Thank you very much, Deborah. So Texas began very similar work with the dual eligible population and really trying to make them more dementia capable. In 2016, we received funding from the Administration on Community Living to begin this work. We are specifically piloting it in 2 counties that have the dual eligible integrated project and that have had a history of great systems change work in their local community. So the grantee, the primary grantee for this project is the Texas Health and Human Services Area Agencies on Aging Office. However, working directly with Baker Ripley, which is a community-based organization in the Houston-Harris County area, as well as the United Way of Tarrant County and the Tarrant County-Fort Worth area. We work closely with our Alzheimer's Association chapter partners in both cases, and then we work with 3 health plans that are in, all 3 are in Harris County, so Molina, United, and AmeriGroup are in Harris, and then we work specifically with AmeriGroup in Tarrant County. So we have a very similar model to California. Build on what works, and that is what we've done with our project. So through our project, we provide education and training as well as screening and identification tools to the health plans so they can better recognize individuals with dementia, they can better recognize stressed caregivers, and then they can actually refer them to different dementia-specific services. We provide them with tools as well. The health plans then identify those individuals and make sure that they are referred to appropriate resources, either resources that they pay for or internal resources or external resources provided by community-based organizations. We specifically outlined some direct services that we wanted the health plans to refer to, and these are the Reach 2 Caregiver Intervention, the Benjamin Rose Institute Care Consultation Program, as well as dementia-specific case management and dementia-specific options counseling. Now, we recognize that we built upon the framework in California. We realized that California and Texas are really very different. And so how we went about this project, we had to add a little bit of a Texas twist to it. So we were able to build upon the framework that was developed in California, the indicators of systems change, a lot of the training material we used with their permission, and I second what Laura and Debra have said. Go to their website. They're fantastic tools. But we had to look at what are some other external factors that we have that either California didn't have or where we're lacking. So we built upon their framework and gave it our little Texas twist. One of the positive factors that we had is we had health plan support from onset. So when we were writing this request for funding, Molina, United, and Amerigroup all said, yes, we want to be a part of that project. So that was great that we had that champion level from the get-go. However, we have minimal policy drivers for dementia care in Texas. As Laura mentioned, the California three-way contract between the state, CMS, and the plans specifically called for a dementia care specialist. We don't have that language in the Texas three-way contract. In fact, the word dementia isn't even mentioned. So it makes it a lot more challenging to implement some of these changes, even if the plans are interested. They don't have a lever to do any sort of systems change that may require costs, like updating electronic health records, things of that nature. But despite that challenge, we have been able to move forward. We've been going slower than we had initially anticipated. As we'll discuss a little bit later about challenges, we've had a lot of reorganization at the state level and within the plans. And so we've had to re-engage champions as we've gone along. And then our other biggest delay has really been that small natural disaster of Hurricane Harvey, and the Houston area is still recovering. However, we feel great about what we have been able to accomplish so far. So a big part of what we did is we wanted to get a baseline assessment of the plans. So what we did is we engaged the plan leaderships and key informants in structured interviews, and we conducted electronic surveys with all of the service coordinators within the health plans. From that, we developed focus group questions and asked people face-to-face about their current dementia practices as well as the culture. We also wanted to understand what are the barriers to providing dementia-friendly services. What are some of the opportunities that we could build on? From there, we developed recommendations for change within each plan. In much of the same way that we do person-centered approaches within our work with individuals with dementia, we called this our plan-specific approach and plan-centered approach. And so each set of recommendations was unique to each plan. We built upon the levers they had in their system. For example, Molina has done this in California. Their recommendations may be different. They may have a set of drivers that they can build upon compared to our other plans. We wanted to look at what is their capacity, what is their willingness to adopt, what is their culture like within their plans related to dementia care. Is this really truly a top-down priority? And then what tools in their system are already in place that we can build upon? So right now, we are in the training and systems change phase. We are building upon the California project materials with our training. We're looking at providing these case managers and service coordinators with basic information on dementia care, communication and interaction tools. We also want to provide them with community resources and tools on how to identify caregiver stress, interact with those caregivers, and educate those caregivers. In terms of systems change, we are starting to see some progress moving forward. One plan has already adopted a screening tool as well as trigger questions in their HRA for cognitive impairment. All three have adopted referral procedures to directly connect people in a warm handoff way to community-based organizations. But what really excites me about this project and what I wanted to share with you all is some of the qualitative information that we received directly from the service coordinators. We wanted to hear from them, what is it that you want to do to improve your ability to serve individuals with dementia? And across all three plans, we heard about these four key topics. One is screening tools. They all recognize that they're very limited in the amount of time that they have to spend with a client. But they all recognize that the tools validate their observations about potential cognitive impairment or concerns, and it helps validate the decisions they make for their service provision, whether it be initiating a specific service or referring to a physician for a diagnosis. So far, the plans have been very interested in the 88, like in California, but we also had one plan adopt the 6 CIT, which is the 6-item cognitive impairment test. The other piece the service coordinators want are better knowledge of community resources. All of them recognize that they do have databases, but they're limited. They do not have good resource-based knowledge of dementia-specific resources in their local service area. They also want to know who is the reliable resource to go to. Resources change on a regular basis, and they want to know who will always be that go-to person in the community for this population. They also want an easy way to refer them. As Debra and Laura mentioned, referrals are sometimes just a phone number given or when a family is in crisis. And they say the part of the reason why is they have very large caseloads and they know that they have minimal time. So they would love an easy referral system to get someone from point A to point B. So what we're doing in Texas is we are building off a pilot program that was done in Houston with Baker Ripley and the Houston Methodist Hospital System. The health plan is able to do a HIPAA compliant email referral to the receiving community-based organization. The community-based organization then triages to the right service as needed and provides follow-up to the health plan. It helps with coordination of care, which is the fourth thing service coordinators say that they really wanted and that they needed. They wanted to be able to work with other organizations, with other resources to ensure that these families, these individuals with dementia and their caregivers are taken care of all the way around. We circle them with care and services. We also asked them what they felt the plan members needed the most. And when they came back, it was again across the board, 4 common things across all 3 plans. So the first was dementia-informed services or dementia-specific services. They want services that are available just for someone who understands or someone with dementia by people that really understand dementia. They also want our safety net services to be better informed of dementia so that there aren't as many barriers to access. Secondly, they requested more dementia-specific adult day centers. In Texas, there is no such thing as a special licensure for dementia-specific day centers. And all of the service coordinators said regular day cares just don't cut it. They don't have the specialized programming or the safety requirements to ensure that the person has the best quality of life. And then finally, they all across the board said there needs to be more caregiver education and respite so that caregivers can continue doing this work for as long as possible. So across the board, both in Texas and in California, there were some key challenges and lessons learned that we experienced. Particularly in Texas, our challenges, as I mentioned before, were the lack of policy drivers and really making dementia care a priority. Some people may be doing this dementia work in individual areas or in silos, but we really need to come together and collaborate at both the community-based organization level, the state level, the federal level, and in the healthcare system overall. So I'll pass it to Laura to talk about a few of the challenges and lessons learned that they experienced in California.
I think actually Debra is going to speak to that.
Okay, this is Debra, and one of the things that I think both we experienced and Katie was a tremendous turnover of our champions and our staff leadership, both at the health plan and the state level. We also found that it was really challenging for our health plans to get meaningful data so that we could look at change in outcomes for the people that were being taken care of by the care managers. Initially, detection of dementia was a real issue until we leveraged policy levers and made it mandatory that it be part of the health risk assessment screen. That helped. It's not perfect, but it does help. As always, caregiver identification, assessment, and support is a challenge. The health plans, at least especially initially, did not see their role, even though they were now responsible for home and community-based services and so forth. They didn't initially see their role as engaging with family caregivers, or be they blood or fictive kin or other caregivers. And in fact, they used HIPAA as a barrier, a statement of a barrier for engaging those caregivers, but that did change over time. And there were also HIPAA-style barriers to connecting with community-based organizations. And for some plans, overcoming that barrier was a lot easier than for other plans. But that ALS Direct Connect form asks family members or a person with the disease, if they're able, do you want to get the phone call from the community-based organization? And they can give permission or not. And I don't know, Katie, if you want to talk anything further about overcoming that lack of policy drivers. For us, it's been a matter of advocacy to make those policy drivers stronger.
Debra, this is Laura. There's just one other thing that I think I would certainly add in, just kind of from trying to do the training perspective. We were dealing with 10 health plans here in California, and I think one of the things, at least when we envisioned this project, we had kind of a prototype of how it would work. What we found, I think, early on was that every health plan, the care management structure was very, very unique to that plan. Some of the health plans were planning on doing their care management using their employees, in-house employees, and they actually were physically located, at a plan site. One health plan, had care managers, but they all worked from home. Some health plans for special populations or for targeted populations were delegating that or subcontracting that care management service. So we just had a wide variety of different configurations in terms of who was doing the care management, and then when it was delegated, the added complications in terms of transmission of data, et cetera, et cetera. So those were just, our motto became, when you see one health plan, you've seen one health plan when it comes to the care management structures. And so that was just a surprising but important lesson to learn and to deal with moving forward.
Well, thank you all for your presentations today. We're going to go ahead and move to questions because quite a few have come in. Katie, do you want to mention anything quickly about challenges and lessons learned before we do that?
As I said, it's making dementia care a priority, and as Debra mentioned, it's really, truly all about advocacy, knocking on those doors, and continuing to knock on those doors.
Great, thank you. I thought I had heard you cut in there, so I wanted to make sure you had a chance. So quite a few questions have come in. Please continue to send those using the question and answer pod on the webinar platform from your desks. One of the questions that came in right at the start has to do with the caregiver assessment tool that was used for the program. Debra and Laura, can you talk about the caregiver assessment tool that you used?
This is Debra. We use the Benjamin Rose Institute's Caregiver Stress and Strain instrument, but one of our health plans is using the AMA's self-assessment, caregiver self-assessment scale. They give different information. The first gives us stress and strain information. The second tool, which is very good as well, identifies caregiver needs, and that can be tied more directly to what the care manager does.
Great, thank you. Another question came in while you were speaking, Katie. can you talk a little, well, everyone can probably talk a little bit more about the issues related to HIPAA and how you overcame some of the actual issues and perceived issues around HIPAA compliance. Katie, can you start and talk a little bit about what services you were able to use to get referrals to the community-based organizations where you were able to comply with HIPAA regulations and any other issues that came up in that area? Yeah. So we took it kind of a two-prong approach. So when we are looking at HIPAA, we look at what is in these referrals. So we created a referral template that allows us to be a little bit vague, a little bit more coded, so that there's not any direct PHI being sent. But additionally, what we did is we set up encrypted and secure email systems both here at the agency and as well as with the referring party. And so it just depends on who the referrer is and how they want to approach that, if it's a fax or an email. And so it's really based on the secure message encryption system that you have set up. Great, thank you. Debra or Laura, do you want to add anything?
Debra, and I would say that it really varied significantly from health plan to health plan, with some health plans able to take a caregiver or the person, but usually it was a caregiver's verbal consent to have a call come to them from an Alzheimer's organization, whereas another health plan created a HIPAA release form and had to have that actually physically signed, and then a call could be, then ALS Direct Connect was used and a call was made. So I just think that it's important to work with each healthcare organization. They have completely different cultures and procedures, and I also believe that HIPAA, that there is some guidance out on HIPAA from the Office of Civil Rights that may be helpful to people, though I'm reluctant to say I know how to get a hold of it. But there should be communication with the patient's permission, and if the patient can't give permission, with the family's permission to prove that you can provide better care.
Great, thank you. Debra, during your presentation you talked a little bit about health plans offering respite. Can you talk a little bit more about that and if any health plans cover or pay for respite services?
Yes, well, this is a duals demonstration, and Medicaid generally across the country pays for a number of home and community-based services. So this unified oversight for medical care and these home and community-based as well as institutional-based long-term services and supports. So through the duals demonstration, MediConnect, health plans were able to increase people's hours, and in fact a recent report suggests that they did increase people's hours for adult day health care, which we call CBAS in California. I think we're just contrary, and for in-home supportive services, which is an in-the-home based, often personal care and other, a list of different services that can be provided in the home that often provide respite as well. Then there was another category of services that the plans could provide with their theoretical cost savings from the program. These care plan options often listed respite, but there are very few examples of respite having been provided, and in fact many of the plans were really overjoyed to learn that through the Administration on Community Living there was a limited amount of respite dollars available through our grant for their members, and they did make use of that.
Great, thank you. For any of you We have one question that came in asking if you had any unexpected feedback from medical providers during or after the care manager training. Was there any resistance to change in how your program was offered and the information they were receiving, et cetera? Is anything from those providers that you can share? And if not, I can move to another question.
You know, what I would say is that we targeted care managers primarily, and then on the system level, we talked a great deal to medical directors. But this was not a strategy that focused on primary care or geriatric providers. It was really focused on the care managers who we saw as the linchpins within the system of care for providing help to people with dementia. A whole other project would have been one that focused more on the medical providers. That wasn't what we were doing.
And in Texas, though, as Deborah said, we weren't focused on the medical providers. One of the things that surprised us overall is we, like California, had asked about caregiver assessments and if people would want to utilize a stress assessment for a caregiver. And one thing that has surprised us is across the board they said, no, we don't need that assessment. We can already tell that they're stressed. We just need to connect them to services. So that was surprising to us that they had no interest in it. They felt very confident in their ability to identify. But we were also very pleased that they said, yes, we recognize it, help us get them connected.
Great, thank you. We had a few questions come in asking if you can talk a little bit more about the evidence-based dementia care management program that was used during the programs that you're implementing.
So our care management program is derived, our care management training program was derived from work done in a program called Access. I think the publication was in 2006 in the New England Journal of Medicine. And the primary author is Barbara Vickery. And we took from that, though I wouldn't call our training program evidence-based, except to the degree that we now have pre, post, and 6-month data that suggests that has self-reported change by those who are trained. But that program from Access trained care managers. It also trained physicians within 3 health care systems in the San Diego marketplace of health plans. And they did do caregiver assessment and then built out best practice care plans that they shared with the care managers that made suggestions like provide caregiver education, provide patient education, refer to a support group. And so we took the structure from Access and some of the content, and with one of their master trainers, we incorporated that into the training we provided in California, and then we used that master trainer to do follow-up case calls, which we offered to the plans once a month after they went through the formal training.
Great, thank you. That's helpful.
And I just wanted to chime in
Go ahead.
For the dementia case, if someone was talking about the dementia case management program being offered in Texas as one of the services that could be referred to, that is not technically an evidence-based program. It is a program that was actually developed through the Houston Alliance to address dementia, and it's here in Houston. And it's a flexible way to address the needs of individuals with dementia who live alone. And if you have further questions, you can feel free to contact me about how we operate that program.
Great, thank you. Well, we are out of time for the hour. Thank you to all our presenters for sharing such useful information for those that participated today. The session was recorded and will be available on the ASA website and also on nadrc.acl.gov. So please tell your colleagues about it, and thank you everyone for attending.